Hi everyone, we're back for part 2 and let's talk about inactivated vaccines. We're first going to talk about diphtheria and tetanus toxoids with pertussis. If you look on the slide, there are two different vaccinations that are given based on the age. For less than 7 years old, you're giving a DTaP, which is an acellular pertussis preparation that has fewer side effects than the whole cell vaccine. And then you're given a Tdap for children greater than 7 years old. It's unknown how long immunity lasts after the pertussis vaccine, but it is known that immunization with either of these products is the only effective control for the disease. Research shows that controlling pertussis in young infants who are the most vulnerable to its complications is the guiding force behind this. So giving booster shots to older children or adults may be seen. This would be a single dose booster with Tdap, and you can go to the CDC website for recommended immunization schedules for this. We also do tetanus prophylaxis as part of wound care, and if you look on table 24-2 in the book, there is a chart regarding tetanus prophylaxis in wound management. For the polio vaccine in the U.S., we only use inactivated polio at this time, the IPV. Next, let's talk about the Haemophilus influenza type B vaccine. Type B is the most virulent and is known to cause pneumonia, meningitis, and epiglottitis in little ones 4 years and younger. For the hepatitis A virus, the goal is to prevent transmission to adults, where the illness is likely to be more serious. Current guidelines include universal vaccination for those 1 to 18 years old and for any subsets of the population that could be at risk. It's currently given in a 2-dose series. The hepatitis B vaccine is given at birth or in early infancy. Individuals that are at high risk, such as dialysis patients or others that are immunocompromised, are not recommended to get routine boosters. The HPV virus, human papillomavirus, is given to both boys and girls. In males, it's to prevent genital warts and male-associated HPV cancers, and in females, to prevent cervical neoplasias. And it can begin as young as 9 years old and go through 26 years old. It is contraindicated in pregnancy. The flu vaccine, it's formulated based on epidemiologic data. It's an annual vaccine for those between 6 months of old and up, unless contraindicated. We know that flu is the highest among children younger than 2 and in those greater than 65 and those with high-risk medical conditions. The meningococcal vaccine, it is felt that this disease is caused by the Neisseria meningitis organism. Most of infections occur in children younger than 5. There's a high morbidity and mortality rate in those who are infected, and there's approximately less than 1,000 infections reported annually. Next, we'll talk about the pneumococcal vaccine. There are 91 known serotypes of the pneumococcus. We know that the pneumococcal conjugate vaccine 13, or the PCV13, covers 13 of those serotypes. It is recommended for all children 2 through 59 months old, for children 24 through 71 months old who have had incomplete schedules or have underlying medical conditions, and for those 6 to 18 years old who are immunocompromised. The PCV23 is recommended for children greater than 2 that are at a high risk of pneumococcal disease. Let's talk a little bit about live vaccines. Some precautions to take into consideration when using live vaccines. Be sure and consult with an infectious disease specialist if giving an immunocompromised patient a live vaccine, and these vaccines cannot be given during IVIG therapy. The first one we're going to talk about is the Bacille Calmette-Guerin vaccine, and it's given to prevent the spread of tuberculosis. It's not routinely used in the United States, though. It is used as a public health measure in about 100 other countries where tuberculosis is more prevalent. For measles, mumps, and rubella vaccine, the measles component is the responsible for the most adverse reactions that are known with the MMR vaccine. This can include rash and fevers and can occur approximately 5 to 12 days after vaccination. Those that do have fever usually have no other symptoms, and the fever generally resolves in about 1 to 2 days. The mumps is part of this vaccine, and it is a live attenuated mumps vaccine. There was a recent outbreak of mumps in 2006, and so there was concern for the immunity of this vaccine, and it may be more shorter than anticipated. The other component and the final component is the rubella vaccine. There can be mild reactions to this component, which include fever, lymphadenopathy, rash, joint pain, and arthralgia. If you have a female that is greater than 13 without documentation of the rubella immunity, and this is noted with a second dose of MMR or by lab confirmation, the focus should be on giving the vaccine. It's important in your postpubertal females to assess for rubella and give the vaccine if needed. Mothers that are found to be rubella non-immune during pregnancy should receive immediate vaccination postpartum. The next is the varicella virus. Administration sites can have localized pain and redness. Others may develop a mild generalized maculopapular rash, and this can occur within 2 weeks of the vaccination. If you have a patient that has been exposed to varicella, there is a post-exposure varicella zoster immunoglobulin, Varizig, and it's available for those whom exposure poses significant risk. You can find that on the last section of table 24.3, and if this is needed to be given, it should be provided within 10 days of exposure. Other options for treatment include IVIG acyclovir within 7 days, or the varicella vaccine given within 3 to 5 days after exposure. The varicella vaccine should be given at 5 months after the Varizig is given, unless the disease occurred despite the Varizig administration. Next, let's talk about the rotavirus vaccine. It's estimated that 4 out of 5 children are likely to be infected with this virus before the age of 5. The child has an increased risk for intussusception after receiving the vaccines, usually occurring within 7 days following the first or the second dose. The only contraindications for this vaccine is a history of intussusception or severe combined immunodeficiency disease. And you can refer to the CDC website for more information on contraindications. The smallpox vaccine is not routinely given. It's given in case of a smallpox outbreak, and this will be determined by CDC guidelines at the time. Let's next talk a little bit about passive immunity and the immunoglobulins. We know that we try to achieve passive immunization by injecting the patient or the individual with a solution of pre-existing antibodies to prevent an infectious disease. These antibodies are taken from the serum of pooled human immunoglobulins. Illness-specific human immunoglobulins, antibodies formulated from animals, or monoclonal antibodies. These are reserved for those who are immunodeficient or have problems making antibodies. They can also be used for patients that are unimmunized or underimmunized who have been exposed to an infectious disease. Let's talk a little bit about RSV and its prophylaxis. Palivizumab, also known as Synagis, is the only product on the American market used for infants at high risk for RSV infections. It is given to infants born before 29 weeks during RSV season until they are up to 12 months old. It is given in 5 monthly IM injections during the season, usually from November through March or April, depending on the region. It can also be given prophylactically for children born before 32 weeks who are less than 2 years and have chronic lung diseases, for infants up to 12 months old with hemodynamically significant cyanosis or congenital heart issues, infants up to 12 months with neuromuscular disorders or congenital respiratory secretions. Okay, that's all on those vaccines. Let's talk a little bit about infections in children in childcare settings. And we know that little ones in childcare settings have 2 to 18 times they're more prone to infectious diseases, and they're more likely to suffer from infectious diseases such as respiratory issues and GI conditions. Also, these kids receive 2 to 4 times more antibiotic treatment and acquire more antibiotic resistant organisms than children that are not in child care. In your book on table 24-4, there is a list of pathogens and mode of transmission that are seen in child care settings. We're going to talk about a few of those. The first one is the enterovirus non-polio. There are about 10 to 15 serotypes that account for this disease. This organism is the most common cause of aseptic meningitis. Manifestations of this virus can include hand, foot, and mouth disease, acute hemorrhagic conjunctivitis, myocarditis, pericarditis, pancreatitis, and some dermatomyositis-like syndromes. Its primary route of invasion is through the GI tract. They spread by fecal-oral contamination, especially in diapered infants. It can also be transmitted via respiratory route. It can be passed via the placenta and can lead to serious diseases in the neonate, including a multi-organ system failure for the liver, heart, meninges, and the adrenal cortex. Some of the clinical findings that you will see in your history is a mild upper respiratory infection, nonspecific fever greater than 3 days, and the onset usually within 2 weeks after delivery. On physical exam, you're going to see a rash that may be macular. It could be macular, papular, urticarial, vesicular, or petechial. The child may also have herpangina, which is a sudden onset of high fever, could be up to as high as 106, lasting for 1 to 4 days. There may be vesicular lesions in the oropharynx or the palate. There's going to be acute lymphonodular pharyngitis. You may see the symptoms of hand, foot, and mouth disease and see vesicles. And for the aseptic meningitis, you will see fever, stiff neck, and a headache. There may also be hemorrhagic conjunctivitis, photophobia, redness. You can look in the book for a little bit more on pleurodenia. You may see orchitis similar to mumps, myocarditis, pericarditis, respiratory symptoms such as wheezing, apnea, asthma exacerbation. Some diagnostic studies that you may consider would be cultures of the throat, stool, cerebral spinal fluid, blood cultures, ordering a PCR that would be highly sensitive. These test results are available in a few hours, and it's more sensitive than a cell culture. Differential diagnosis include viral and bacterial causes, and the management of this condition is supportive. There's no known specific therapy. IVIG has been given and is often seen as helpful in helping with chronic and life-threatening infections. The next enterovirus is poliomyelitis virus, and it's an asymptomatic illness that involves the CNS. Transmission is from fecal, oral, and respiratory routes. Humans are the only documented source of infections, and almost all cases in North America occur in children, most likely exposed to children who had received oral polio vaccines in another country. It is a nonspecific febrile illness. You may see aseptic meningitis and paralytic symptoms. You would test with a culture from the stool or the throat, 2 samples approximately 24 hours apart. as soon as polio is suspected and at least within 14 days of the onset of symptoms. If the child has paralytic symptoms, it's important to exclude other illnesses, and management is supportive and is directed at minimizing skeletal deformities based on the paralytic form of the disease. Next, let's talk about the hepatovirus or the Hep A virus. We know that the Hep A virus causes primarily infection in the liver. It's passed person to person and through the fecal-oral transmission. Less than 10% of young children develop jaundice, and only 30% are symptomatic, so it allows for a rapid spread. The incubation period is from 15 to 50 days, with the average being 28 to 30 days. The virus is usually shed anywhere from 1 to 3 weeks, and the highest time when the disease could be spread is during the 2-week period before the onset of the illness until 1 week after the onset of jaundice. In our clinical findings, there's a pre-icteric phase where you'll see acute febrile illness. You may see malaise, nausea, vomiting, anorexia, stomach issues, and may have right upper quadrant pain due to the infection in the liver. In the icteric phase, jaundice will begin shortly after the onset of symptoms and can last for a few days to a month. You'll note dark urine, clay-colored stools. They may feel sick. Poor weight gain is seen in infants. Fulminant disease is rare, and that's when there's acute liver failure, and you will see complete recovery in 1 to 2 months, and there may be an occasional relapse up to 6 months. Serological testing is done, and you may see IgM-specific antibodies that will indicate a recent infection, and these may be replaced by IgG-specific antibodies if retested in 2 to 4 months, and this serves as an indicator of past infections. You may note elevations in the AST and ALT, and these may precede the symptoms by about a week, and these will indicate the degree of inflammation in the liver. Differential diagnoses in infancy could include physiological jaundice, hemolytic disease, galactosemia, hypothyroidism, biliary disorders, and an elevated vitamin A level. In older kids and older infants, children, and adults, you could see hemolytic uremic syndrome, Reye's syndrome. There can also be a chronic hemolytic disease with gallstone development. Management of Hep A is supportive and trying to decrease complications and prevent further issues. Good hand hygiene is imperative after diaper changes to prevent spread of the disease, especially for child care personnel. Immunoglobulins or the hepatitis A vaccine should be given within 2 weeks of exposure. It's important for adults that may work in the school system or as food handlers, if they are known to have an active infection, to be excluded from work for a week after the onset of symptoms. Prevention also includes safe drinking water, in addition to the routine vaccine for those that are 12 months and older. Next, let's talk about hepatitis B. We know that it's highly contagious and can cause severe liver damage. It is transmitted through blood and body fluids. There can be perinatal transmission. Greater than 90% of infants will develop chronic illnesses if untreated. On our clinical findings, the incubation period is anywhere from 45 to 160 days, with the average being 120. There's a wide range of the illness from asymptomatic seroconversion to liver failure and death. It usually has a gradual onset, and most kids who acquired Hep B at an early age are asymptomatic. Early on, you may see some nonspecific symptoms such as fever, nausea, mild hepatomegaly, and later these symptoms will worsen as you get into the icteric phase. As with Hep A, the diagnostic studies that you'll do are serological testing, and then you will see changes in the liver enzymes related to the degree of injury. The differential diagnosis could be anything that might cause jaundice. Management would include dealing with the acute infection and offering supportive care. There has been discussion of active and passive vaccination for these kids. It would be important to refer to a Hep B specialist, a pediatric Hep B specialist, for the management of reactivation of Hep B. Currently, there are 5 medications approved for use of chronic Hep B in kids by the FDA. You can read more about that in the book. Let's talk a little bit about the Hep C virus, and then we'll close out this segment of the video. It's a chronic disease that's spread through blood. 15 to 25% of the kids will not develop any issues, and it will resolve spontaneously without treatment. The perinatal route is a major way of transmitting the virus for children, and approximately 6 out of every 100 infants born to hepatitis C moms are infected. Moms that are HIV positive have a 2 to 3-fold increased likelihood of transmitting the virus to their infants. Vaginal birth and breastfeeding do not contribute to the rate of transmission, and women that just have the Hep C virus alone should not be discouraged from experiencing either of these processes. After infancy, the most common route of transmission in the U.S. is through IV drug use, and it's estimated that 1/3 of IV drug users between the ages of 18 and 30 are infected. Clinical findings show that Hep C has an incubation period ranging from 2 weeks to 6 months, with an average of 45 days. Most children are asymptomatic, and there can be a flu-like prodromal phase, such as jaundice, nausea, anorexia, and upper quadrant pain that may occur in 20 to 30% of older children. Complete liver failure is uncommon, and often teenagers may be discovered to be hepatitis C positive when they're being screened for other reasons, such as a school blood drive. There's no serological markers to indicate acute infection. Confirmation of Hep C is done by Ig antibody enzyme assays, but there may be false negatives in the early stages. Liver function test will be altered when the disease occurs. In your differential diagnosis, you also have to rule out Hep A and Hep B. Management is supportive. Chronic Hep C infections in kids 3 through 17 respond to interferon and ribavirin. There's a lot of advertisements out on new Hep C treatments, but those are not indicated at this time for kids. We know with Hep C that there's going to be liver involvement, so drugs such as Tylenol or other antiretroviral medications need to be closely monitored, and liver assays done periodically. These kids don't need to be excluded from child care facilities, so they can continue to be out in the public. As these kids get older, it's important to discourage the use of alcohol, as this can cause further liver damage. It's also important to discourage sharing razors and toothbrushes, and when they're being sexually active, it's important to use condoms. Okay, let's wrap this one up for specific viral diseases. We'll come back for number 3.